I'm Andrew Sharp. I'm a consultant cardiologist from University College Dublin in Ireland, and I've got a really excellent panel here. We have Professor Robert Arians from Leeds, who's a world expert on platelet and clot biology. We have Stavros Konstantinidis from Mainz, who chaired the 2019 European Society of Cardiology Guidelines. And we have Jakub Stefnewski from Poland, a very high volume operator who can bring a lot of experience to bear with cases. I realize that obviously it's lunchtime, so hopefully people can just find their seats and I'll get up and get started on my slides. Great. So, as I say, I'm Andrew Sharp, cardiologist from Dublin, involved with various of these clinical trials, and my conflicts of interest include all the PE catheter companies. So let's get started. So there's various risk scoring algorithms, and it doesn't really matter which one I pick. I picked the BOVA score here, which is a risk stratification tool for intermediate high-risk PE. So intermediate high-risk PE, pulmonary embolism causing right heart strain, defined by a rise in troponin and abnormal right ventricle on either echo or CT, usually on CT. And then you're trying to work out which of these patients with intermediate high-risk PE fall over. And this is one of them. So I put a theoretical patient in here, a patient with a preserved blood pressure over 100, a patient with an elevated troponin, a patient with RV dysfunction on CT, just a dilated right ventricle, and a heart rate of 115. So what is the risk of that? So this is one of many risk scoring algorithms that we always instinctively don't believe when we look at the outcome, but it is extraordinary. So 42% risk of PE-related complications in this patient, which consists of death, hemodynamic collapse, or recurrent PE at 30 days, and a 10% mortality. That is extraordinary for a blockage in a pipe. We've managed to get STEMI mortalities down to 2% if you don't have shock. These are patients who don't have shock, and yet we've got mortalities 5 times as high. So there's no question that there's unmet need in pulmonary embolism. So we're going to focus today around the EKOS device. This is ultrasound-assisted catheter-directed thrombolysis. It's a very simple device, so its strongest asset is that anyone can do it. We could probably train non-interventionists to use this device. It's 2 6-French devices via the leg or the neck. About 90% of cases are done via the leg, via the femoral vein. And then you do 2 6-French side-by-side punctures. You put 2 catheters up, one in the left lung, one in the right lung. And then these catheters have holes in them. And using ultrasound, it drives droplets of alteplase up into the clot. So it's like injecting alteplase thrombolytic directly inside the clot. And it does so over a period of between 2 and 6 hours, as we did in the Optalize study, and some people do longer infusions than that. So could CDT work better than systemic thrombolysis mil for mil? Well, systemic TPA does clear clot. If you give enough TPA, you'll clear clot. And the FDA recommended regimen for high-risk pulmonary embolism is 100 milligrams of alteplase for an adult male. That is a massive dose, a gigantic dose. And why do we have to give such a gigantic dose? Well, this cartoon shows if you have an occluded right interlobar artery, you give this infusion, and most of the infusion will go away from the clot. So if you've got an occluded vessel, all it can do is salami slice that clot each time it goes around the circulation. Whereas if you wire and inject into this clot directly, you're getting greater surface area of contact. And as we'll hear from Professor Arians, you get much more surface area of contact if you use ultrasound augmentation. So this is what the devices look like. They go into the lower lobes, but the ultrasound effect goes throughout the lung. And when you hear Professor Arians describe the effect on clot morphology, this is a pan-lung effect of exposing binding sites, even if you inject the alteplase into the lower lobes. So I will pass on now to Robert, and we'll hear a little bit about the bench model he worked on that tries to explain how this technology works. Thank you.
Thank you very much, Professor Sharp. Good afternoon, ladies and gentlemen. My name is Robert Arians. I'm a scientist. I'm a professor of vascular biology at the University of Leeds in the United Kingdom. And today I will discuss the impact of ultrasounds on clot structure and how that regulates fibrinolysis. These are my disclosures. For the work that I'm presenting here today, I received a researcher-led grant award from Boston Scientific. So as you all know, thrombosis is a lead cause of mortality worldwide. So if we take together all the numbers from thrombosis associated with myocardial infarction, stroke, and venous thromboembolism, then thrombosis is associated with 4.3 million deaths per year in Europe alone. And of that, 300,000 are associated with venous thromboembolism and pulmonary embolism. And the ultimate cause of death is the formation of a blood clot that blocks the circulation, leading to tissue ischemia. Now, this is a electron micrograph of a clot that we obtained from a patient with an abdominal aortic aneurysm. And you can clearly see the blood cells there associated with the clot, but at the background, this gray matter, that's all fibrin. And we know from increasing number of studies that fibrin structure is really important for the clot. So there's more than 400 papers on the topic of clot structure in the last 5 years alone, showing that dense clot structures with smaller pores are more resistant to lysis and increase the risk of thrombosis, both in case control studies and in longitudinal studies. So here you can see a couple of examples on the right of a healthy clot and one on the right, far right, of a clot from a patient with thrombosis. And you can see that there's much more densely packed fibrin fibers and there's smaller pores. And this increases the risk of thrombosis, it increases the risk of recurrence, and it increases mortality in longitudinal studies. So that's where the EKOS system comes in, which is, as Professor Sharp has explained, a catheter-mediated TPA delivery device, which is ultrasound-assisted, and it brings TPA right to the clot where it's needed in the pulmonary circulation. But what we don't know is how ultrasounds impact on fibrinolysis. And that was the focus of our study. So here we aim to develop, first of all, a benchtop EKOS system in vitro to look at clots and the effects of the EKOS catheter ultrasound-mediated delivery on clot structure, fibrin fiber size, pore size, and fibrinolysis. We also wanted to know if the effects were reversible and whether we can reduce the dose of TPA in our in vitro system if we apply ultrasounds. So we developed these 4 systems. The first one where we looked at clot structure using light scattering in a spectrophotometer. The next system we looked at pore size by using a buffer permeation method. And the third one we looked at clot structure, fibrin fiber thickness using scanning electron microscopy. And then the fourth system we looked at lysis and the ultrasound effect on lysis, both in a static situation and in a situation where we allow for flow to regain through the clot. So let's have a look at the data. This is the first data set. So on the left, you have the data of fibrin clot structure by light scattering. The higher the maximum absorbency, the thicker the fibers. In the middle, you see a zoom in of that left-hand panel on the area where we applied the ultrasounds, which is the gray background area. And then on the right, we see the analysis of the data. And you can clearly see, especially here in the zoomed-in panel, that ultrasounds decrease the maximum absorbency, indicating thinner fibers in a dose-dependent manner, and that occurs within minutes of the application of ultrasound and is stable thereafter. So and that's depicted in this slide here. Next, we wanted to know if these effects, and these are studies now done without TPA, just the ultrasound, we wanted to know if the effects are reversible. So here you can see we applied ultrasounds for only 15 minutes, and looked again, you can see very clearly with 2 doses of ultrasounds, we get the thinning of fibrin fibers within minutes. But as soon as the ultrasounds are stopped, the fibrin fibers regain their original thickness. And that's depicted here on the right-hand side, where we look at fibrin fiber thickness change. And you can see that this happens within 5 minutes of application of ultrasounds. After that, they stay thin. And then when, upon cessation of ultrasounds, the fibrin thickness bounces back and stays stable again after that. Now, to confirm that ultrasounds change fibrin fiber thickness, we next applied ultrasounds, and then we fixed the clots, and we processed them for scanning electron microscopy. And you can see quite clearly in these images here, the panels on the right, that the fibers are much thinner when ultrasound is applied as for the same clot before application of ultrasound. And so when we analyze those data for fibrin fiber thickness, we see that the fibrin fibers are reduced by a thickness of about 15 nanometer in the presence of ultrasounds. So we have a change in fibrin fiber thickness. What about the pores that are in between these fibers? Do they get larger when the fibers get thinner? And the answer to that question is yes. So you can see that here. So we use the permeation setup to look at buffer flow through the clot. And you can see that there's a 37% increase in average pore size when we apply ultrasounds. And in the panel on the right, you can also see that, again, this effect is fully reversible after cessation of ultrasounds. So remember, those were all data without TPA, so just an effect on clot structure, thinner fibrin fibers, larger pores. So what happens when we apply now TPA? We see a clear dose-dependent increase in fibrinolysis rates here on the left. So lysis takes place much quicker. So in the same clot with a dose of 50 nanomolar TPA without ultrasounds, lysis takes place in this clot in about 40 minutes, and that's half to about 20 minutes in the presence of the highest dose of ultrasounds. And when we look at different stages of lysis, so a quarter of the clot lyse, half of the clot lyse, 75% lyse, or fully lyse, at each of these stages, ultrasounds dose-dependently enhance fibrinolysis. That system was in a static system, so there was no flow. So what happens if flow restores? And that you can see here, when we allow flow to occur through the clot, now we don't have a linear dose-dependent relationship, but now the increase of fibrinolysis over time is exponential in the presence of ultrasound, and you can see that in both in terms of the buffer flowing through the clot as well as the D-dimer fibrin degradation product coming out of the other end of the clot. The final question we wanted to address is, can we reduce the dose of TPA then in the presence of lysis? So we tested 2 doses of TPA, a high dose, 50 nanomolar, the 2 red lines here on the left, and then a lower dose at 37.5 nanomolar TPA in the purple lines on the right. And you can see that with the lower dose, lysis is very slow, taking place over about 90 minutes instead of 40 minutes. But if we apply ultrasounds, the lysis of these clots is accelerated to the higher dose of TPA. And you can see that also on the right-hand side, that ultrasounds can indeed reduce the dose of TPA for a comparable thrombolytic effect. Now, if you want to know more about the data and the study that we did, then I'd refer you to this paper. It came out just a couple of months ago in Hematologica. It's open access, so anybody can have a look at that and read more about how we did the study. So with that, I'm going to wrap up and with some key take-home messages. First of all, we've discussed how fibrin clot structure is really critical in thrombosis. Dense clots increase the risk of recurrence and death. Now, the application of ultrasounds actually thins fibrin fibers. It also enlarges the pores between the fibers, and that consequently has an effect on fibrinolysis, which increases exponentially once flow is being restored. The other thing we've seen is that the effects are fully reversible within minutes of cessation of ultrasound. And we've also shown, at least in the in vitro system, that ultrasound can lower the dose of TPA for a comparable thrombolytic effect. I'd like to thank the team back in Leeds, many of whom have contributed to the study, and Boston Scientific for the funding of our study. And I'll leave you with that same key point slide from earlier. Thank you.
Thanks, Robert. So if anyone's got any questions, they can either come to the microphone or put them through the app, and then we'll see them here. So, Robert, just a couple of points of clarification. The ultrasound is reversible, but that's because you tested ultrasound without lytic. If you add lytic, it then becomes irreversible, that lysis occurs, correct?
Correct, yes, that's correct. So.
And the way I've thought of this, having had you explain this to me, is it's almost like the ultrasound turns a hairdryer on. It sort of aligns all the fibers and creates more space between the molecules. I mean, I realize that's a bit cartoonish, but is that a way that they can think about it?
Yes, I think it's a good analogy. Yeah. It's a sort of compacting them, the fibers themselves, giving larger pores, giving more access of lytic enzymes inside that clot.
And more binding sites.
Yes.
And so one of the interesting conclusions we came to in the manuscript is that for years we've been looking at a relatively high dose of lytic, and then we add ultrasound on top, not realizing we're effectively increasing the dose by 50%. So perhaps the addition of ultrasound should be compared for a dose and then a lower dose, because we're potentiating it. We're making a smaller dose of lytic more powerful.
Yes, I'd agree with that, but I'd put a slight caveat that this was, of course, in vitro data in a benchtop system. Yeah. But yes, and if anything, we saw more of an effect of the ultrasounds at the lower dose of TPA than at the higher dose. So, yeah.
Fascinating. Stavros?
Yeah, Robert, great work, really. Beautiful translational work. Of course, it's in vitro, but still, it's very important to see these effects. I have one comment and one brief question. The comment is, for me, the most important thing from the clinician's point of view is that the acceleration takes place, right, of the action of the fibrinolysis, which means so the fibrinolytic acts faster. And this is because ultimately most thrombi will lyse by themselves if the patient survives, however, right? So what we want in such an intermediate high or close to high risk situation is to act faster. So I think that's very important. And my question is, would you think, I don't know if you have done such work, or would you hypothesize that this effect might also help to lyse thrombi that are not so terribly fresh, so a little older, and maybe so have some, because there's so much discussion about acute and chronic and how chronic is chronic, right? So there are all the continuum of age of the thrombi. So what would you think on that?
Yeah, that's a great question. It's something I would like to test, actually, and see if the same applies to older thrombi. We haven't done that yet, but that's certainly something we can do.
There's a
question. Hi, Erin.
Hello, thank you for this great study. I was waiting. There's data on DVT where ultrasound didn't do anything. Could you please comment on that work? So the ultrasound didn't add any more to the lytic. What would you say? Did they use a different frequency, or what was the reason for inefficiency?
It's difficult to answer that question, but I suspect it's to do with how resistant that clot is in general to lysis, and that even if we have an enhancing effect of ultrasounds, it maybe just couldn't still do the job. But I'd be happy to hear any other opinions.
In many ways, it speaks to Stavros's previous clarification. What we've learned from this work is it allows dose reduction and faster lysis. And we've not tested either of those metrics in any of the studies except Optelyse. So in Optelyse for pulmonary embolism, we showed that an 8 milligram dose can offload the right ventricle at 48 hours. And all of the studies have a 24, 48-hour timeline. But what Robert's work suggests is that we are getting recovery earlier, potentially. We don't know that. But the promise is lower dose, faster recovery. But the trial designs have not tested that. They've only looked distantly. And so same with ATTRACT, we didn't see a clinical difference in DVT, but a lot of those were chronic, and the metrics were taken at a distant time point rather than early. So it could be that it's less important in DVT to reperfuse the leg earlier, but you can imagine how it could be important in pulmonary embolism. If you can make someone's recovery begin at 1 to 2 hours instead of 5 or 6 hours, that could have importance. Question?
Thank you for this great talk. My name is Cihangir Kaymaz from Turkey. In our recently published data from our single-center EKOS study showed that in comparison to standard anticoagulation regimen in patients with intermediate high-risk PE population, EKOSing thrombolysis provided higher improvement in oxygen saturation, pulse oxygen saturation, heart rate, canal obstruction score, pulmonary arterial pressure reduction as assessed by transient echocardiography. And besides these benefits, hemodynamic benefits in hemodynamic and echocardiography measures of pulmonary embolism severity, there was a small increase in major and minor bleeding rate and non-significant 30% reduction in mortality, favoring the EKOSing thrombolysis over standard anticoagulation in patients with intermediate high-risk PE. But this is non-randomized data based on...
Perfect. You've set up the next talk. Thank you. We're going to go to Stavros, who's hopefully going to expand on our colleagues' favorable local data with a randomized trial looking to see whether the use of this technology can improve outcomes over and above anticoagulation in 544 patients. So Stavros?
Thank you very much, Andrew, and hello also from my side. So let's move now to the clinical field, the field of clinical trials, and see how this clinical evaluation of the ecosystem in acute pulmonary embolism is taking place as we speak, and how a trial was designed that will hopefully be a state-of-the-art trial and address the important questions that everyone needs to know when we treat severe pulmonary embolism. These are my conflicts of interest, potentially. And so we are dealing here with, I would say, severe pulmonary embolism. What is that? It's those two categories. So the high risk, the patients who are manifestly in cardiogenic or obstructive shock. I mean, this is a small minority of patients. And we're talking about the larger group of what we call intermediate or intermediate high risk PE, patients who are not manifestly unstable, but have signs of right ventricular dysfunction, have signs, so clinically, by imaging and by biomarkers. So these are patients in whom decompensation is threatening or is imminent. So it's about these patients and how we help them and how could advanced therapy, advanced reperfusion therapy, and in this case, catheter-directed thrombolysis with ultrasound assistance help. Now, guidelines do not help us. Guidelines are from the year 29. Back then, we had a very small volume of data. And the consensus paper that was published actually in Eurointervention, the journal also of this meeting, in 2022, actually reiterated the guidelines recommendations. There were nothing new. Of course, you see that optically now CDT is, so catheter-directed therapy in general is placed in the middle and is optically, let's say, the main treatment of PE. But of course, I mean, if you read between the lines, it is said that it is still considered second line to thrombolysis, and even if there are contraindications to thrombolysis, and this is both for high risk and intermediate high risk PE. Is this true in 2025? Well, yes and no. Formally, it is still true because we are waiting for the studies, the big studies, to answer the question. And these are the studies that are ongoing right now. So we'll talk about the HI-PEITHO study, but there are also studies like PEERLESS-2 testing a large bore mechanical thrombectomy, an academic trial on PE tract focusing on long-term outcomes. There's also an academic trial focusing on low-dose systemic thrombolysis. So when we are testing these procedures in patients with intermediate high risk, there are a couple of things that we have to pay particular attention to when we're designing such a trial. Whom we are testing, what we are testing, and of course, what is our outcome. You'll say, of course, this is evident, but it is not as clear as it seems, and this is what we had to learn. For example, we did learn from the PEERLESS study that was published a couple of months ago, big trial in pulmonary embolism. We learned that intermediate risk PE is not so clear to define. So it's not so clear to define who really would benefit from ELYSIS. You may take some symptoms, or you may take a little RV dysfunction or a biomarker, but at the end of the day, if you have, of course, groups that had mortality of 0.0 or 0.4%, that means one should enrich the criteria rather and have patients who are really before decompensation and who are not just having a little large ventricle. These patients will probably do well without any kind of catheter therapy at all. And what we also learned, of course, and this is the most important thing, we knew that when we designed HI-PEITHO, but we learned it from the studies that were published as well indirectly, namely that in open label studies, and any catheter study is essentially open labeled, of course, you have to set clear criteria that are standardized, criteria that can be, that are justifiable when to perform rescue therapy, when to bail out the patient, and as one says, because otherwise there would be arbitrary crossover, and that will destroy the validity and the integrity of the trial. So there are some things that one has to pay attention to. And these are aspects that the HI-PEITHO trial, which will be is approaching completion and will be the first large state-of-the-art trial testing any kind of catheter interventional treatment in acute PE, the modern era, has tried to address. So there is, of course, a randomization regimen, and there is a clear window of 6 hours, right, from the moment that acute intermediate risk PE is confirmed until therapy is initiated, if this is ultrasound-assisted catheter direction thrombolysis. So this is okay. There has to be a clear window, because if we take too long, then of course we may start including recovering patients, and this will also mean nothing for the study. But what is also important is that we no longer rely simply on RV dysfunction on echo, as we did in the PEITHO thrombolysis study 15 years ago, because this is not enough. RVLV of 1.02 to 1 is not a sign that the patient is dying of PE. So there are simple but important enrichment criteria, clinical criteria, that are based on the patient's vital parameters and help us say that this patient is, let's say, borderline. Patients should not be allowed to be in cardiogenic or obstructive shock. This is not the idea, but they should be close to this, so the physician should have the impression this is someone who really, I believe, needs help. So I need this study to show if we can help these patients. And these were not criteria just because we thought, okay, a vital parameter should make sense, let's use it. But it was based on a post hoc analysis of the first PEITHO trial, which is a very large trial, you may remember, some of you, more than 1,000 patients. And we did find that patients with at least 2 criteria based on vital parameters, or in that case also in heart failure, if patients fulfilled these criteria, they had a high rate of events, as you can see in the placebo arm of 20%, and back then in the thrombolysis arm this was reduced by 2/3. We used, of course, more conservative estimates for the purpose of designing the present trial. And then we have the primary outcome. Okay, so the primary outcome should be, of course, if someone dies or has cardiac arrest, or if someone has signs of shock, or patient needs to be placed on ECMO. But it was clear we have to be able to allow by protocol the physicians, the investigations to intervene before it comes to that. We cannot wait until patient comes into shock to say patient did not do well on one kind of treatment. On the other hand, we cannot allow everyone to say, well, I think patient is not doing very well, so let's cross over or let's bail out, because this would be also difficult. And this is the simple idea that came also actually by Professor Sharp and other colleagues who are used to this also in their clinical practice in the UK, in the Netherlands, in Nordic countries. And there it's actually a score, a dynamic score based on the patient's vital parameters, which may indicate to you, we took the level of 9, which may indicate to you that the patient is decompensating before they come into shock. And this is an objective means to say that the patient is doing worse without having to use some kind of next generation mathematics. So it is quite simple to use, and it is something that is also being done by the nursing personnel, by the nurses in the in ICUs or intermediate care units. And then, of course, there is also other important outcomes that have to be considered in such a trial, secondary outcomes, and these are the long-term. Many physicians believe that catheter-directed thrombolysis may reduce the risk of CTEPH, for example. This is not known. I mean, this is speculation, makes sense theoretically, but it needs to be shown. So this is being tested. And of course, quality of life estimates. It's not about who dies and who lives. The question how well patients feel. And many patients after PE do not feel very well. So hopefully there will also be an improvement. And also healthcare resource utilization, because not every catheter that is more expensive than heparin is something that is less cost effective. Actually, the opposite may be true. So there are several strengths of the trial design. The entry criteria have to be enriched. Patients who really need something more than heparin. Control arm has to be the current standard of care. You cannot start comparing different methods before you have compared to the standard of care. Primary outcome should also be pragmatic and standardized in the, at the same time. There is, of course, a probe design, independent adjudication, and standardized thrombolysis, not just everyone doing local protocol, but some standardized protocol of catheter-directed thrombolysis and anticoagulations, and clear rules to prevent arbitrary crossover. So the study is very close to completion. It has enrolled more than 95% of the patients. So at the end of this year or in the beginning of the next year, the study results should become available. And we believe it is a state-of-the-art randomized trial. It will be the first large state-of-the-art randomized trial comparing to current standard of care, as I said, in modern era advanced treatment of PE. So finally, this is just my last slide to show, is the future of severe PE interventional? That was the question for my talk. It is not only interventional, because there are some patients in whom it will still be okay to treat with systemic thrombolysis, but clearly interventional catheter-directed treatment for PE is effective, it is safe, it has been shown in uncontrolled studies, it will very soon it is being tested, and the results will be available from the large RCTs. So I believe for a large proportion, with the help of the pulmonary embolism response teams, the multidisciplinary teams on site at each hospital, it will be possible to find the right therapy for the right patient, and also do it now or very soon on the basis of clear evidence which will be solid and will help to guide our decisions. Thank you.
Thanks, Stavros. Any questions from the floor? If you're shy, you can put them through the app. Okay, Stavros, so question number one is, let's imagine HI-PEITHO is positive. It shows a difference in favor of the catheter treatment. What happens next?
So, if the study is positive, one thing that is important to emphasize it, of course, it shows the superiority of the device versus standard of care, and it is also a more general message showing that advanced treatment, catheter-directed treatment, has a clear place in acute pulmonary embolism. We know that it is being practiced, but it has to be shown by the trial. I mean, the next thing is, of course, when this study appears, that studies are then this RCT, other RCTs that will become available over the next year or two, are being evaluated by guidelines task forces, and guidelines then are base their recommendation on these studies. And I believe such a study is definitely one of the, let's say, guidelines informing trials. And then, so we do have recommendations by the European Society of Cardiology, by North American societies. And then, of course, this means that for the first time, there can be recommendations. I do not know what the wording will be. We'll have to wait for the messages, but there will be recommendations that are evidence-based, and we will stop having this discussion. I've had a long experience with this. You know, when it's about drugs, everyone says, well, tens of thousands of people included, very clear in favor of the drug A or B. And for catheters, I mean, more conservative physicians said, well, you know, a couple of patients, that's not really a serious study. So this will stop, that we will have high-quality data now on catheter treatment of PE. I think that's very important. That would be the first time we've had it for this disease.
And I think in the next 2 years, we've got this extraordinary once-in-a-lifetime lattice of clinical trials.
Yes.
With thrombectomy, with using cardiopulmonary exercise testing in PE tract, using EKOS here. We're going to be able to put all these data together and really answer this question once and for all, I think.
And I mean, we can say that many of you know this. It's public information that the next guidelines of the ESC will be in 2027. So I think that they will be able to capture almost all of the studies that are now, you know, approaching completion. And that will be that's really a once-in-a-lifetime chance.
Okay. Thanks very much. In the interest of time, we better move on. So thank you, Stavros. So I'll now ask Dr. Jakub Stepanewski to come up and show a couple of cases.
Hello, everyone. Thank you very much for having me here. It's my great privilege to be. I'll show you one case. This is I'm reporting this potential conflict of interest. I will try with my presentation to paint an illustration to what has been said so far. I hope that with this presentation we'll be able to get an idea how to apply modern approach to patient selection for catheter-based reperfusion therapies. I will take you through the EKOS procedure so that you could recognize the simplicity of it. And also, I hope that the discussion at the end will kind of help you get hints how to optimize the EKOS care or peri-procedural care. So let's go to the case directly. This was a 62-year-old gentleman. He had no past medical history or any significant VT risk factors. He had been experiencing dyspnea, or proper to say, loss of exercise tolerance for the preceding 3 days. until he developed a few episodes of syncope, and that made him finally seek for medical help. At a presentation, he was non-hypotensive patient. We can see that his systolic blood pressure was high, 156, but at the same time he was tachycardic, 110 beats per minute. The saturation was very low and practically refractory to high doses of oxygen supplementation, and he also experienced this increased distress or respiratory distress. He was brought to the peripheral hospital outside of our center. NGCT revealed bilateral pulmonary artery clots. On the right-hand side, right pulmonary artery, the clots were a little more proximal. On the left pulmonary artery, a little more distal. The NGCT also revealed highly dysfunctional right ventricle with a right ventricular to left ventricular diameter ratio of 2.5. So at this point, the diagnosis of acute PE was done, confirmed, and the anticoagulation was started. The doctor called us in, and I mean us, we are an expert PE center that is providing 24/7 service to acute pulmonary patients within our region. And together with this doctor, we decided that we will bring this patient to our center for further care. At admission to our center, the clinical status of the patient didn't change much. If we take these three elements into consideration, so first on your left-hand side is the PESI score that represents the clinical signs of cardiopulmonary compromise. The second element is the elevation of troponin levels or NT-proBNP levels that represent the biochemical markers of right ventricular struggle. And then on the right side is the RV ratio. So that taking this all together, we defined the risk of the severity of this PE episode as intermediate high. And as Professor Konstantinidis said, this translates into around 10 to 20% of early death because of acute PE. We included this patient in the HI-PEITHO trial. The patient was randomized to an anticoagulation arm. So our job was to continue anticoagulation and closely monitor the patient. After 24 hours, the clinical status of the patient didn't change much. It's been discussed by Professor Konstantinidis, we used the new score, so the early warning score, designed to guide clinical decision in acutely ill patients. It was calculated 2 times. So we identified a non-improvement of this clinical scenario of intermediate high-risk patient despite anticoagulation. This is obvious or also seen in the NT-proBNP levels or biochemical markers that are elevating. Also, the lactates are steadily elevated. So within our repair team, we decided that anticoagulation probably will not be enough for this patient, and we would like to proceed. We decided to proceed with a catheter, with a reperfusion intervention. Every time when we decide which strategy, reperfusion strategy to choose, we always closely evaluate the NGCT grams. And then we found that in this patient, there might be a right to left shunting. You can see it clearly when you look at the left ventricle, it's all white at the same time as the right ventricle. It should not be like this. And then if you closely look at the interarterial septum, there is a gap. So then this would explain why the patient had this refractory hypoxemia, especially without any changes in the lung parenchyma in this patient. So my question to panel and obviously to the audience, what would be your reperfusion strategy, knowing the clinical status of the patient, knowing the clot burden and distribution, and also having in mind that the patient might having the right to left shunting. Is the systemic thrombolysis following the guidelines the best option? Is the catheter-directed embolectomy, or maybe catheter-directed thrombolysis with EKOS? Difficult. Probably systemic thrombolysis. Probably in this situation would not be a good idea. As at least this is how we imagine this. Part of the systematically given lysis would go to the left heart, and then probably not work. So we decided to go for low dose lysis. First of all, because we had this impression that the clot will be susceptible to lysis. So because the duration of symptoms was only 3 days, this was a rather acute onset, and the D-dimers were high. And secondly, we had some worries that when we enter with a larger device, then it could kind of reshape the heart and then increase the right to left shunting. And sometimes these patients do not tolerate it well. We usually, for the EKOS procedures, we use femoral vein access. I'm showing this picture to show that jugular vein access is also feasible. We always use ultrasound-guided puncture. For practical reasons, we use a 12 French dual-lumen hemostatic catheter sheath. And then the rest of the devices or equipment is pretty simple. This is all available in any cath lab around the world. We use the angulated PEITHO catheter to cross the heart. We always take measurement, hemodynamic parameters, and I'll show you this in a second. I'd like to draw your attention to the yellow box. It tells that it's 7:29. This is the moment when we're actually entering the pulmonary circulation. I would like to you to remember this hour. These are the hemodynamic parameters. If you closely look, the pulmonary artery pressures are elevated, cardiac index is low, and total pulmonary resistance is also elevated. When the wire is put distally in pulmonary circulation, we use it to deliver the EKOS infusion catheter. You can appreciate how quickly and how smoothly it travels through the heart and enters the pulmonary artery. If you look at, we try to put the treatments on. It's defined by 2 markers, where in the place where the highest burden of clot is located. We are not trying to go too far. And then the second step is to insert the ultrasonic core. You can see this on your right-hand side. And in order to deliver the acoustic energy into the clot. This is the moment when we inject the alteplase bolus of 2 milligrams according to the HiPeitho protocol and start the alteplase infusion 1 milligram per hour per catheter for a duration of 7 hours. And usually these patients get around 18 to 12 to 20 milligrams of ultrasound-assisted TPA. We repeat these steps. It's now 7:47, so less than 10 minutes later, to insert the left lung catheter. And we finish the procedure. The patient it took us 18 minutes, probably from patient on the cath table and off. It will be less than 30 minutes. In this case, it was probably 20 minutes when we included the puncture of the vein. And the patient is brought back to the department. And this is my next question. Where should the patient be monitored? There has been some discussion recently that the many patients with EKOS should be or are monitored in the ICU care. This is always financial problems, but also the ICU is usually, the space in the ICU is very limited. So I asked myself the question whether intensive care unit, cardiac intensive care unit, or monitored bed in the cardiology ward, which of these would be most appropriate?
Well, we've just got 1 minute left, but this is a patient in shock, right? Mm-hmm. You've demonstrated they're in shock on cardiac index. So I think it's reasonable clinically for intensive care, but there's no need at all for intensive care in order to deliver EKOS catheter-directed thrombolysis. Yes, I went through our data of all intermediate high-risk PE patients to compare the safety and efficacy of all patients depending on the stratified by the place where they are monitored. You can see that there are 64 patients treated with CDL throughout these years. 2 patients were monitored on the ICU. The remainder was treated either on the regular bed, monitored or CICU. And you can see that those patients who were treated or monitored on the regular bed, they had no worse outcome. They had no more
rates of hemorrhagic complication or anything like this. So what drives, this is what Professor Sharp said, what probably drives where the patient is, the decision where the patient is monitored is the clinical status of the patient and not the fact that the patient is treated with EKOS. Treatment results, hemodynamics nicely improved. We usually take hemodynamics when we are removing the catheter. We do it at the bedside. We never take the patient to the cath lab to remove the catheters. You can see that the improvement is also confirmed on the echo. The right ventricular is improving. And also, what is most important for this patient, saturation improved. Somewhere in the middle of the treatment, the patient relieved and gained this respiratory comfort. We could decrease the O2 supplementation. The patient was discharged on the 4th postoperative day on DOACs. He only had mild exercise limitation. So to conclude, EKOS provides improvement in the right ventricle, is capable of providing improvement in right ventricular function and pulmonary perfusion, enables timely reperfusion in appropriate selected patients, delivers low-dose thrombolytic therapy directed to the clot, and is a minimally invasive with low complication rate procedure and has a straightforward logistics. 1 second, please. An invitation to Krakow this autumn for an expert PE conference, the great event where not only very complicated, but all aspects of PE care will be discussed. You're warmly welcome. Thank you very much for your attention.
I formally endorse that invitation. I'm going. It's going to be a great conference. Listen, we're out of time, but I will just ask one very short question, very short answer. How quickly did the patient get better on EKOS?
It's about 3-4 hours. It depends. It very depends on the clinical status and other markers, but usually it's about in the mid-time.
Okay, great. Well, I wish we had more time, but we've run to the end of our session. So, Stavros, I'll ask you for one final comment, and then we'll all get on our way.
Yeah, I think it's as you concluded, Jakub. This is a system that works. This is a system that works safely. So it is already in practice, and many patients have been helped and saved. And now we need the data from randomized controlled trials to be able to also formally have the recommendations on the use of advanced therapy. Thank you very much from my side.